Thank you very much, Craig. And from show of hands at the back, can you hear me okay? Raise of hands. Great. Okay. So, Craig, I have to say I was so impressed with you saying the last name. That was absolutely perfect. And so you either had a lot of coaching beforehand, because the last name, just for reference, is Ukrainian in background, but it really doesn't sound Ukrainian anymore. So I get a lot of different pronunciations of that last name, and that was exactly correct. So, as was already introduced, I'm a physician in Samaritan Health Services. I've been with Samaritan Health for 18 years, but I was born and raised in Saskatchewan in Western Canada. So if you still hear a little bit of my dialect come through, especially if I say the word about, you can tease me at the break. We've been here in Oregon for 18 years, and moving to Western or Western United States from Western Canada was really not much of a culture shock. And I had the opportunity to work and practice medicine in Canada, and now been practicing medicine here in the United States. I'm board certified in family medicine in both Canada and the United States, and the reason why I chose to keep my board certification in Canada wasn't just for the possibility of moving back. We've been here 18 years, so I think we're pretty safe to say that we're staying here. But there's a lot of good references and communication that come from the Canadian Board of Family Practice. And there's a lot to be said from learning from different countries, learning from different communities, learning from different systems. And this is why I chose to keep my board certification, because I have access to all of those really good things that are happening in other countries, to see how we can collaborate and really try to produce the best type of healthcare system that we can do for our participants. So, welcome to such a great forum. We're really excited to see so many people here today. And we're all here this morning because we really want the best for our communities, and we're also intrigued on how we can get there collaboratively. If you look again, aligning for better health, aligning is such a good, positive action word. And better health, who could argue against the need for better health for all of us? We want to go through this journey of life as healthy as we can. And in order to do this, it's really, really important to understand the basic building blocks of health. We may have seen pie graphs in the past that outline the factors that influence our health outcomes. And 10% is our genetics, our DNA. It's what makes us. 25% is the influence of the healthcare system, meaning the doctors we go to, the hospitals we may be admitted to. But over 50%, well over 50% now, is our lifestyle. And what are the building blocks of many of those lifestyle factors? The social determinants of health are those building blocks. According to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, live, work, and age. And these circumstances are shaped by the distribution of money, power, and resources at a global level, a national level, and here at our local level. The social determinants of health are responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. Nationally, the Office of Disease Prevention and Health Promotion have a goal of creating social and physical environments that promote good health for all. Health starts in our homes, our schools, our workplaces, our neighborhoods, and communities. We know that taking good care of ourselves by eating well and staying active, not smoking, getting the recommended immunizations and screening tests, seeing a doctor or healthcare provider when we are sick, they all influence our health. But our health is also determined in part by access to social and economic opportunities, the resources and supports available in our homes, our neighborhoods and communities, the quality of our schooling, the safety of our workplaces, the cleanliness of our water, food, and air, and the nature of our social interactions and relationships. And all these conditions in which we live explain in part why some Americans are healthier than others, and why Americans more generally are not as healthy as they could be. Healthy People 2020 highlights the importance of addressing the social determinants of health by including create social and physical environments that promote good health for all. It's a wonderful statement. And that's one of its overarching goals for this decade that we're in. If we look at the conditions in the various environments and settings that we interact, whether it's the workplace, our church, our neighborhood, our school, we can refer to this as place. And in addition to the more material attributes of place, the patterns of social engagement and the sense of security and well-being are also affected by where people live. Resources that improve quality of life can also have a significant influence on population health outcomes. Examples of these include safe and affordable housing, access to education, public safety, availability of healthy foods, local emergency and health services, and environments free of life-threatening toxins. But one of the most important of the social determinants is availability of resources to meet daily needs. Safe and affordable housing is a key daily need. Poor housing conditions are associated with a wide range of health conditions, including respiratory infections, asthma, lead poisoning, injuries, and mental health. Public health has long been involved in housing issues, and in the 19th century, health officials targeted poor sanitation, crowding, inadequate ventilation to reduce infectious diseases, as well as fire hazards to decrease injuries. Today, public health departments across the nation can employ multiple strategies to improve housing, such as developing and enforcing housing guidelines and codes, implementing healthy homes programs to improve indoor environmental quality, assessing housing conditions, and advocating for healthy, affordable housing. So now is really the time for our collective communities to create healthier homes by confronting substandard housing. Housing is an important determinant of health, and substandard housing is a major public health issue. Each year in the United States, 13.5 million non-fatal injuries occur in and around the home. 2,900 people die in house fires, and 2 million people make emergency room visits for asthma. 1 million young children in the United States have blood lead levels high enough to adversely affect their intelligence, behavior, and development, and this is our generation that's growing up. 2 million Americans occupy homes that have severe physical problems, and an additional 4.8 live in homes with moderate problems. Our elected officials and communities are recognizing that substandard housing is an important social justice issue that adversely influences health. Features of this substandard housing include lack of safe drinking water, something many of us may take for granted, the absence of hot water for washing, ineffective waste disposal, intrusion by disease vectors, insects and rodents, and inadequate food storage have long been identified as contributing to the spread of infectious disease. Crowding is associated with transmission of respiratory illnesses and tuberculosis. And in more recent years, epidemiological studies have linked substandard housing with an increased risk of chronic illness. Damp, cold, and moldy housing is associated with asthma and other chronic respiratory symptoms, even after we take away the confounding factors such as income, social class, smoking, crowding, and unemployment. Damp houses provide a nurturing environment, not for humans, but for mites, roaches, respiratory viruses, and molds, all of which play a role in respiratory disease. And cross-sectional epidemiological studies have also established associations between damp and moldy housing and recurrent headaches, fever, nausea and vomiting, and sore throats. Pest infestations like cockroaches and rodents can cause allergic sensitization and higher risks for hospitalization from asthma. Changes in indoor temperature beyond a relatively narrow range for humans has been associated with an increased risk of cardiovascular disease. Living in cold housing has been associated with lower general health status and increased use of health services overall. And these health concerns have contributed to the development of standards for thermal comfort in our homes. Exposure to toxic substances found in homes can also result in chronic health problems. Indoor tobacco smoke, poor ventilation, exposure to volatile compounds from various particle board, floor coverings, etc., elevated levels of carbon monoxide from poorly functioning heating systems, lead and radon exposures, all of these have negative health side effects. But substandard housing can also adversely affect mental health. Excessive indoor temperature has been linked with irritability and social intolerance. Damp, moldy, and cold indoor conditions may be associated with anxiety and depression. A study in Glasgow demonstrated that dampness was significantly and independently associated with poorer mental health. So good luck for Oregon. Crowding was associated with psychological distress amongst women aged 25 to 45 years of age in London. And homelessness and living in substandard housing has been related to behavioral problems amongst children. Substandard housing may also lead to social isolation because occupants are reluctant to invite guests into their homes. Recent analyses have examined the influence of childhood housing conditions on the subsequent development of chronic diseases. And a study conducted in Britain demonstrated that modest associations of inadequate ventilation had overall mortality and type of water supply with increased coronary heart disease mortality. And this was independent of other measures of deprivation. So another study suggested that recurrent periods of housing deprivation during a participant's first 33 years of life were associated with increased disability or severe ill health. Lack of affordable housing has been linked to inadequate nutrition, especially among children. Relatively expensive housing may force low-income tenants to use more of their resources to obtain shelter, leaving less for other necessities like food. And children from low-income families receiving housing subsidies showed increased growth compared to children whose families were on a subsidy waiting list. An observation consistent with the idea that subsidies do provide a protective effect against childhood undernutrition. Numerous studies have also shown that when people who have been chronically homeless are housed and supported, their medical expenses go down and quality of life improves. This has been linked with decreased emergency room utilization and decreased hospitalization. So I wanted to close things out with a patient story. Tommy is an 8-year-old boy. He lives with his mother and 4 other siblings in a dwelling. Some may call it a house, but it is not a home. A house is a structure. A home is nurturing and caring. This structure is not a nurturing place. The family sleeps together in one room, on mattresses that were collected from the sides of the street, ever so abundant when the student population moves. The mattresses were initially somewhat clean, but have grown a darker black haze on them over the years, particularly the mattresses closer to the wall. And also, that same black haze, particularly the wall that has the window in it, the window that never shuts fully and has that drip, drip, drip whenever it rains. Tommy finds it hard to breathe. For as long as he can remember, he has had a chronic cough. Many always thought it was related to various colds that he had picked up, but he wondered if it was just normal to always feel short of breath. But it gets to the point that he cannot run around at school anymore at recess time. He really wishes he could play soccer, as it is his favorite sport to watch. But every time that he has tried playing, he was so short of breath and coughed so much that he couldn't get a full breath of air. And that took him to the emergency room, and x-rays were done, pulmonary function testing was done, medications given through machines for his lungs to breathe. And there have been times that he was so short of breath and his oxygen levels were so dangerously low, he spent a few days in the hospital, admitted. This actually occurred 3 times in the previous year. When he had his follow-up visits after the hospitalization, his primary care physicians didn't get any of the notes. So they did what they thought best: increase inhalers, add new inhalers, because he still wasn't breathing well. They didn't know what the home situation was like. So they added a second inhaler, a third inhaler, eventually adding oral prednisone, which is a steroid, to try to get on top of his asthma symptoms. While this finally started getting control of his symptoms, he remained on the prednisone for quite some time because he could not breathe well without it. Now Tommy and his mother are even more frustrated because his doctor now told him that he's developed type 2 diabetes, likely as a result of the long-term oral prednisone that he needed to take to help his breathing. Tommy really hates checking his blood sugars with that darn finger poke. He would much rather play soccer, but he still feels weak. He doesn't eat as much as he used to because he finds it hard to breathe well when he is eating. So he takes only a few bites of food and then he quits. He finds it hard to concentrate at school because he has these headaches every single day and he doesn't know why. His teachers let his mother know that he is not thriving in school, that he is not growing educationally like his peers. His doctors let them know that he is not growing well, developmentally or physically. And the black mold that is on the mattresses and on the walls of his dwelling continues to grow and grow and grow. So thank you for all being here today and help us build a healthier community together. Thank you. I next wanted to take this opportunity to introduce a very well-known person in the healthcare setting, and that is Kim Whitley. Kim obtained her master's in public administration from the University of Idaho, has been with Samaritan Health Services for the past 15 years, and is the Chief Operating Officer of Samaritan Health Plans and InterCommunity Health Network CCO. Many in the Albany area also know Kim to be a very vocal advocate and civic person. She has a heart of gold, and she is going to be leading us today as our panel discussion moderator. So Kim.
Thank you, Dr. Ewanchyna. He did a fabulous job of setting the stage. That was incredible. He also mentioned two things that it's part of the reason that I have a lot of passion I wanted to share with everybody. Mold and the University of Idaho. So when I was getting my master's degree at the University of Idaho, I just had my youngest son, he was 20. I mean, he's 20 today, but I just had my youngest son. He was 2.11 pounds when I had him in Moscow, Idaho, so it was quite a trip to be in a very small hospital and have such a small child and trying to obtain my master's degree at the same time. Ironically enough, I was a social worker for a HUD building in Pullman, Washington, where I was trying to improve the health of people over the age of 65. And at the same time, I had this small 2.11 pound child in married student housing at the University of Idaho. And he would quit breathing in the middle of the night, and I didn't know why. And we didn't have health insurance because we were trying to do all these things. We were trying to graduate. We had two other kids. We were trying to make things work. And so we didn't go to the doctor. And I would sleep under his crib at night, trying to make sure that he would stay awake. I mean, he would stay alive all through the night. And we finally figured out what it was. We were cleaning out the closet in his room, and there was black mold all the way through that building. And we called the University of Idaho and we said, you know, this is not acceptable. And they said, sorry, there's nothing we can do about it. And so, you know, we did what we could. We wiped the walls with bleach, but the mold would grow back. So we lived in that place for 2 years. And to this day, he does have respiratory problems. So his first 33 days of life were in a place exposed to mold. So it is unfortunate. And the most unfortunate thing I think about that is that if it wasn't for the support that we had while we were there, we wouldn't have survived. I mean, those things would have kept us from obtaining our degrees, from going on and being successful individuals and being able to contribute to communities. And so many of our OHP members don't have the support they need to bust through those barriers and become effective individuals in our community. And so I'm so glad that you're all here today, because that's what we're here to do. We're here to support the people in our community who are being oppressed by these, whether it's social determinants of health or other things that are barriers to them becoming effective and happy individuals in our community who can contribute and make this a better place. So thank you for being here. There are 3 goals that we're trying to achieve today. They're at table tents on your table. So I'm just going to read through the goals. Our goals here today are awareness and education, aligning our core values, needs, and priorities, and setting a foundation for funding opportunities. So we're going to start to do that by having a panel discussion of health and then a panel discussion of housing. And our goal is to help raise the awareness and education for all of us on what we're currently doing, what's available, so that we can then have table conversations later where we look to align and see where we can come together to focus on issues that we're finding in our communities that are becoming barriers for our members. So we have some structured questions that I'm going to be asking our panelists in order to do that. And if we have time, we will open questions, have an open question time, but I'm not anticipating that because we have a lot to get through. So if you have questions, we will get to them if we're able, but if not, then this afternoon at your tables would be the opportunity to document those.